So children and teens in foster care have been removed from their home primarily for safety situations. These kids, these babies, teens, they've suffered abuse, they've suffered neglect, they've suffered trauma. And you could imagine that that weighs in on their mental health and it affects their development. And actually nationwide, the research shows about 80% of kids really struggle in foster care with mental health conditions like PTSD or depression, anxiety. And we're really going to dive into this topic today. I'm joined on our Foster Leader podcast with Meambi and Chris, who are both part of our clinical team at Clark County Family Services. So welcome, you guys. Thank you so much for being here with us today.
Thank you for having us.
Thanks for having us.
Yeah,
Yes,
let's start
absolutely.
with an intro and give me, a little bit about your role, what you do at Family Services. And Meambi, let's start with you.
So I'm a licensed clinical social worker. I've been working with Family Services for 17 years. And at this moment, I oversee, as a manager, our clinical services team. We provide an array of services to our youth that includes direct services, crisis intervention, support. We do a lot of care coordination for their mental health services. So I oversee 3 amazing teams that's serving these children every single day.
Wow, 17 years is a big commitment to our kids.
Yes.
Wonderful. Thank you for your service.
Absolutely. Yeah.
Chris, what's your role with Family Services?
So I am a fancy title, a youth and adult intervention specialist, and I work underneath Meambi. And basically what that means is we're just providing clinical support to both the children in our care on the Child Haven campus, and then from our other teams, we provide different types of support to kids and foster parents. And in my specific case, we provide support and advisement to the caregivers that are in the what we call cottages at Child Haven. We also, like Meambi said, we get the children mental health services. We do screenings. We do crisis assessments. And anything that you could imagine related to mental health related concerns, both on campus and out in the community, we try to help support.
So let's start kind of at a baseline. Some of our viewers, this might be the first time that they're watching Foster Leader podcast. So we just want to educate families and people out there watching or listening on why children are coming into foster care. What are I know it's trauma and abuse and neglect, but what are some of the situations that we're seeing bringing children into foster care?
No, I would say that most of our cases that we are responding to are due to neglect. There are situations that are happening in a child's environment, various social determinants of health, poverty, lack of resources, things like that, that really that our families are struggling, and maybe the parents are not as well equipped to meet those basic needs. So those are the majority of the cases. I think that we see maybe 80+% of those cases come to our attention as a result of neglect. And then we see a spectrum of abuse or observing violence in the home. Domestic violence, I think, is really a huge concern that brings children and families to our attention, where we need to intervene and support our families.
So there's neglect, which could be like failure to provide shelter or food, sometimes even medical care or
Basic needs.
Educational neglect, right? Let's talk a little bit about emotional neglect. What does that look like for a child?
Emotional neglect can very well look like a parent that's really struggling maybe with just parenting in general. There's stressors that are occurring, again, usually due to a lack of resources. And so that parent is stressed. And so maybe they're not as readily available, or they're actively parenting, or they're responding to typical behavior from a child, and they're not able to respond appropriately to a toddler that's fussy or very busy and things like that. And so they're reactive in their parenting, and they may say or do things that are not appropriate for that child.
Everybody is like coining this term ACEs. So can you tell us a little bit more about these ACEs and what we're seeing with our kids in foster care when it comes to these adverse childhood experiences?
Mm-hmm.
We're really starting to understand what these adverse experiences, which are potentially traumatic events that happen before the age of 18, we're seeing what types of effects they have later on in life, whether it be mental health issues and also a variety of physical concerns. So elevated risk for cancer, heart disease, more substance use, smoking, things like that. And we're finally starting to understand a little bit about what those processes are. But this research goes back all the way to the late 80s, early 90s, and it was mostly ignored. I think partially because it was really hard for the average person and also physicians from the medical model and legislatures and folks that come from kind of an older school view of life. It's hard for them to understand that these early experiences, often even before the age of 2, could have any impact at all later on in life. So what this early study in the late 90s did was it established a survey of 10 common childhood adversities, and it compared them to a really large representative sample of something like 17,000 middle-class folks that were on Kaiser Permanente's insurance rolls. They had jobs. They were living in Southern California. And what they found was that the more ACEs that someone had experienced, the worse outcomes for a wide variety of health and mental health related concerns. So that initial study found that 4 or more ACEs raised your risk for alcoholism, for example, by 1,200%. And for context, the children that we see on the Child Haven campus and by extension that go into foster care sometimes have 6, 7, 8, 9, 10 adverse childhood experiences. And so the effect is magnified almost beyond belief.
What you said about the ACEs really can become like a physical effect too. There's a book, I don't know if you've read The Body Keeps Score.
Absolutely.
Bessel van der Kolk.
Yes, exactly. And so I think that it's so important that as caregivers, as foster caregivers or relative caregivers or biological parents or whoever it is that's caring for children, it's like a situation might happen, stress might be going on in the home,
Right.
but that situation might live with your child into their adulthood.
Trauma impacts mental health, physical health, neural development as well. And one thing I would add, I think Chris really did a great overview explaining ACEs and kind of the concept and what our current understanding is to it of the issue and how prevalent it is. But it's important to note that trauma is also based off of perspective. So there's perceived, right? We may all see one significant event happen in front of us, and my experience and Chris's experience and your experience is based on how we take that experience in. Then we're going to have it's going to impact us in very individual ways. So it's really important not to minimize experiences. And, these experiences extend beyond a child's home. So community violence, right? Unfortunately, someone may grow up in a community where, there's poverty or not as many financial resources. So they're growing up in an area for the rent that they can afford. And all those things that are happening in the community, crime, trafficking, things like that they're observing also has a traumatic impact. So we really need to expand our perspective on that and consider all of those pieces.
And considering that, talking about being in that neighborhood where there's a lot of crime, where there's, a lot of this going on, it's like this trauma then becomes normalized to these children. But what would really be refreshing is if seeking help and getting support is normalized in those communities as well. But if we can all start to normalize, maybe it's just support that we need to go to their WIC office, to ask their pediatrician, hey, what do I do when my kid is like falling out and kicking and screaming and we're trying to get out the door, right? Because then maybe our families might have a better toolkit on how to approach some of these scenarios.
Well, you know what makes it easier for folks to seek that help and talk about it is the people in our profession, in the medical profession, asking the question of what happened to you. You know, Vincent Felitti, one of the primary authors of that original ACE study, he talked about getting a letter from a woman years later after she participated in the study that just simply said, "Thank you for asking. I thought I was going to go to my grave without anybody knowing." She was talking about sexual abuse, but it could have been any number of things. And especially back then, but we're getting better now, is making it okay by asking the question and saying, hey, has anything like this happened? Even just with a simple survey like the ACE survey, where it's distant, it's not face-to-face, it's just something that's filled out, and then we can follow up with it. Can normalize that seeking help by a person in authority, letting them know that, you know, we're thinking about them and this might affect you and we want to know.
Yeah, it's about prioritizing the conversation. And, you know, in reference to what Chris mentioned, that's a big part of our role at Child Haven as a team. You know, there's very specific screening tools that we use to, you know, start the conversation and elicit that feedback. And, you know, I agree with you wholeheartedly. It's really important that we're prioritizing mental health, but we're normalizing it. You know, we need to have the same concerns for mental health and stability as we do with physical health and our kids' education. And so we have those things as paramount. We understand that those things are important, but social and emotional health and that development, I think just targeting the developmental needs of a child beyond, you know, just their education or if they're growing adequately or if they're physically ill, but social and emotional and their emotional challenges, are we really being sure that we're really asking those questions and looking into that? That's really key, I think.
So the kids at Child Haven and children in foster care in general, what types of mental health concerns are you seeing?
Yeah, you want me to answer?
Of course.
Okay. Well, the mental health concerns that kiddos on campus are experiencing are what you'd expect and maybe what you wouldn't, primarily chronic stress, trauma, PTSD, grief if they've lost a parent, or grief if they haven't, just being removed from their caregiving environment, even if it wasn't the healthiest one, can be difficult and traumatizing.
I think that grief and that loss, too, of if they're separated from their siblings or if they are not in the same neighborhood or going to their normal church or their school. Yeah, that's a lot of grief. That's a lot of loss.
Absolutely.
And how do they process this? What does it look like?
Oh, well, it can show up in a whole number of different ways. It could show up in what we as adults would consider grief, of just withdrawal and tearfulness and isolation. It could show up in hyperactive and acting out behaviors and aggressive behaviors. It really spans the whole spectrum. You know, some of the other mental health related concerns that we see on campus and that we're really starting to understand have a root in childhood trauma are things like schizophrenia, or mood disorders like bipolar disorder, conduct related issues, oppositional related issues, impulsivity, ADHD. It really spans the entire spectrum of what we call the DSM, our diagnosis Bible, in ways that I didn't even understand when I first started doing this.
So tell me a little bit about, like, you know, oppositional. That's a big term that maybe people don't know. What is, break that down for us.
Well, I almost regret that I brought it up because I really don't like that diagnosis and I don't like that term. Basically, it's labeling a child based on their externalizing behaviors. So that's defiant, saying no, throwing tantrums that are beyond what you would consider reasonable for the situation, aggressive behaviors, bullying behaviors potentially, and that lead into more conduct-related issues, if not addressed kind of in adolescence and teenage years and early adulthood, that could get a kid into substance abuse or get in trouble with the law or things like that. But I think my distaste with that diagnosis itself is that we're starting to really understand that it too is very well rooted in childhood trauma.
Trauma, yeah. I was going to say, ultimately, the etiology of all of these diagnoses is trauma, right? So we may have some genetic predisposition to depression or things like that, but usually what sparks it is trauma. And treating the trauma and having an understanding of that, what trauma reactivity looks like, especially in a child, it's going to show up in uncooperative behavior, which is what I that's how I reframe, oppositional defiant behavior is uncooperative behavior. And guess what? Because we seek to be trauma informed, I'm responsive to that in a sensitive and compassionate way. When we understand that most trauma, especially the kids that we're serving, that trauma is occurring in the context of a relationship. Mm-hmm. So I expect you not to trust me. I expect you to, reject, right, what I'm trying to show you because you've had unsafe experiences. It's important to understand that trauma really shapes our worldview, how we perceive ourselves, how we perceive adults and people that are supposed to protect us, and how we just perceive the community and the world around us. So if that narrative is people aren't safe, the world is bad, adults don't care about me and they're harmful to me, then that's going to show up in any new relationships that this child is trying to form. So we have to practice that understanding and practice that in how we're forming relationships with these children. We need to be trauma informed in our approach.
And I see what you're saying about that too. And I think about, like developmentally, like middle schoolers, teenagers, they're trying to get their needs met too. And their need is independence. And, if you have been neglected and don't trust people and you've had to work to get your own needs met,
yes,
like you're a fighter because you're fighting every day to make sure that you have food, that you are safe, right? And so I can see how that comes off as being oppositional, but that child, that might be their survival tactics at that point too, right?
Absolutely. Yes.
So, okay, let's talk about the types of services on Child Haven campus. For those that are watching for the first time and haven't heard about Child Haven is our emergency shelter where children who don't have a safe home to return to, if there's unsafe situations and family services has to remove the child from an unsafe situation, our first go-to is try to find some relatives, some family friends. Then we move on to a licensed foster home. And sometimes because we do have such a lack of shortage of foster parents in Clark County, sometimes our children do end up in congregate care at our emergency shelter, Child Haven, where these wonderful people work and offer mental health services to the children on campus and kids in foster care in general. So talk with me about a child comes in to Child Haven, unsafe situation, they're new in foster care, they're new at Child Haven. What does your team do?
So the first thing that happens, and it's actually outside of our team, it's right at intake. The intake professionals go over a screening that Meambi mentioned earlier. We call it an acuity screening, meaning is there acute concerns related to mental health issues. It covers things like suicidal thoughts. It covers a wide array of potential mental health and physical symptoms. And it covers a little bit about self-perceived mental health related concerns like self-harm or if you believe you've experienced trauma, et cetera. And it's really a wide angle 30,000 foot view of what the child believes that they are experiencing And then based on that score, we follow up with the children. And we actually try to follow up with every kid that comes in, whether they fill out one of those or not, whether it's a high or low score, because we understand that it's a jarring and overwhelming experience for many to be in an unfamiliar place that's often loud and raucous. And unfortunately, we have many kids on campus that are waiting to find a home or return back to their parents' home. So we're checking in with them initially. We're asking kind of follow-up questions, like I said, based on need, that kind of what happened to you question. And do you want to talk about it? And is there anybody, anything that you do want to know? So we're really just looking for, is there a need for more mental health related services? We put the ball in the children's court, so to speak, and say, hey, have you ever had therapy? Do you know what therapy is? Do you want therapy? Some kids have, many have, and some say no. And we try to respect that to the best of our ability and then continue to monitor. So our broad goal on campus as campus clinical is to do those screenings, to support and monitor those children, to make relationships with them, even in a non-clinical way.
And I've seen that. My office is on campus, so sometimes I'll be walking through and I'll see you playing basketball with the kids, or like they'll put some music on and everybody will just kind of be like hanging out together. And I think that type of relationship building, like Meambi said, these kids are not going to trust us right away. And especially you're coming to Child Haven, you don't know anybody else. You're with other children who have also experienced trauma. You have clinicians that might not look like you or might not, share in your same cultures or whatever. And I think it takes those like off the cuff moments, and just like you might be hanging out with the kids, just like our foster parents. We had a really great interview with Bruce. He's a foster parent and he fosters a lot of teens. And he said, I just let the kids come in. I'll take them grocery shopping. Hey, what do you guys want for your lunches? Pick out whatever you want. And when you're ready, if you go in your room and you shut your door and you shut me out for the first few weeks, fine. But I'm going to be here when you're ready.
Absolutely.
Right? And so that's kind of what I'm hearing from you too.
Yeah.
Yes, it's really important to meet them where they are, really to be able to address and start there and really alter how we engage, and the fancy term I think we use for that in literature is important to facilitate psychological safety. So that's really what we're aiming to do at that point. Start where the kid is, and then we go from there. Let them guide, right? What helps them to feel safe, because we have the capacity to do that as adults. So it's important that we're flexible and we're adaptive. And I think, that's one reason I really love the work that we do on campus in particular. I think it's a unique skill set, very specific to clinicians that work in child welfare. And Chris is grinning because he knows how I feel about that, is we really take some very eclectic and unconventional approaches to be able to connect with our kids, because it's a challenge because of the harm that they've experienced.
So I can see, like kids that are verbal, middle schoolers that might be able to put more words to their emotions, teens that have, maybe been through this once or twice before, but our littles, like our, 2-year-olds, our 3-year-olds, our 4-year-olds, what do services look like for these little ones?
Yes. So we're really, really mindful to ensure that we are collaborating with our state partners that really specialize in that area. Early childhood mental health is a specialization. It's important that we are really offering some evidence-based approaches to that. So currently right now we partner with NEIS and early childhood mental health, and our state partners, they come onto campus and we're regularly screening those children, and we're doing those early intervention screeners for them. We see a lot of regression in their development. So we're really kind of looking at, okay, this child is 2, but they appear to, in their functioning, to be months behind, maybe even a year behind. And so it's important that early intervention services are expedited.
And some of that regression might be like if a child who's already potty trained, like starts wetting the bed or having accidents again, or, like tantrums or irritability that's beyond, manageable, right?
We see it in speech delay as well. So we have, a lot of our kids that are coming in on campus. We're definitely screening for developmental concerns. So a lot of them have developmental delays, failure to thrive. We see that show up in their eating and their sleeping and head banging and lack of verbal skills and things of that sort. So we want to expedite services for those kids. And we have a great process in partnership with our state partners to ensure that those specialists are coming onto campus to help us out with those children.
What does it look like for school age kids? What kind of issues are we seeing? What kind of behaviors? What are like some red flags that...
Similar regression-related issues, bedwetting can be a big sign of trauma, changes in sleep, appetite, things like that. I see a lot of physical concerns and complaints, kids getting sick often, frequent infections, headaches, stomach aches, things like that. And then it just depends on the individual child and what they've gone through. I kind of see two camps. I see sort of the anxious, depressive side where it's like withdrawn and nervous and overwhelmed and difficulty sleeping. And then I see the more externalizing types that we talked about earlier with defiance and staff complaining of having a difficult time with essentially parenting them, caregiving for them. So getting them along with their programs that they run and learning the way that the Child Haven campus works and some just overall, I guess, difficulty with social relationships, whether it be with other kids or staff. I notice it kind of falls into those two main categories at the school age.
And I think social relationships is something that a lot of kids are struggling with ever since the pandemic.
Absolutely.
What kind of changes have you seen? Meambi, you've been with Family Services for 17 years. So are the issues amplified after the pandemic? Are they about the same? Like, do kids need more services? Are there more specialized needs? Like, what do you see as the change?
Yeah, children can only develop and thrive through healthy relationships. And so that's with adults, that's with healthy adults, that's with peer interaction. So through the pandemic, our kids were isolated and they did not get their appropriate social and emotional development, like that normalcy that we would see when I was growing up, and having community involvement in my church and a village that really helped me to develop into the person that I am today. And then so we see diminished core values, right? Because through those relationships, we're taught values. And so we see struggles with boundaries. We see struggles with getting needs met, as you mentioned before, in an appropriate way. And so how to reparent that and redirect that is challenged. Uncooperative behavior develops very quickly, right? If my needs are not met and I have to break the rules to get my needs met, then reshaping that takes time. It takes patience. And it takes a reshaping of that value, that core value that's misperceived and what's acceptable or it's not acceptable. I think we see that a lot more often lately. And not just in our kids that are in care, I just think community-wide. So we're noticing that it's really important within our schools to prioritize social and emotional development. We see an uptick of bullying, school refusal. Kids are afraid to go to school because of the experiences they're having with their peers and relationships and those struggles. And so I think we're in crisis as a community in regards to that. As an outcome of the pandemic, it's important that it's on everyone's radar and we're really targeting that issue.
The bullying, I think that, it's so common, going back for years and years and years and years and years. And I just couldn't even imagine a child in foster care that is already suffering grief, going through trauma, and then they have to go to school. And wouldn't you just naturally feel different? I mean, couldn't you imagine just feeling like I must be different because I live in a shelter?
I had a teenager about a year ago come back livid, upset, and he told me, so-and-so, my pickup from Child Haven, walked into the office and all my peers saw. said, "Hey, I'm so and so. I'm coming to pick up Joey from Child Haven," and he was so embarrassed and so ashamed, just from the jump, and he came back fighting mad because of it. I think that's just one example of, rightly or not, that shame that children feel surrounding their situation and where they're at and what their peers may or may not think about them.
And I think that brings up a good point on, yes, we have Child Haven. Yes, we have some place to keep children safe, but kids ultimately belong in families.
Absolutely.
Like, I know you guys are doing a great job, caring for these kids and meeting their mental health needs, but nothing quite makes you feel warm and cozy and cared for and important, right? We want these kids to feel like they matter in our society, that we're equipping them with the skills, that we're equipping them with a support system, and nothing quite like that is like going to a home, sleeping in a bedroom with, like someone tucking you in at night, like eating your homemade, like home-cooked dinner that, your mom makes is different than being in congregate care and sitting around a table with, 10 other kids, 12 other kids. So talk with me about, like, when we see our kids move from Child Haven into foster homes, do you still have contact with these kids? Like, what does that look like?
Yeah, so we recently implemented a process with our clinical team where we really want to screen, or I would say be mindful, I think is the most appropriate word. Be mindful of kids maybe that have been at Child Haven a really long time, and understand that their transition into a family setting is difficult for them. It's anxiety evoking, and they've had all these relationships that they've built on campus. A lot of time is with our team. And so we did develop a process where we have we support those transitions. So we will follow them to the home. If they're going to a relative or fictive kin, whatever that placement looks like, especially if it's out of home, like they're not going home. We will follow them for about a month or 3 weeks or so. We talk to them about what that looks like. We process that with them and what their fears are. When foster families are there to pick them up, and we help facilitate and support those conversations, so they're empowered to ask the question, identify and articulate their needs. And that helps them to feel safer, right? And feeling safe ultimately takes time. Like, it's a process, but understanding that we have to be intentional in every engagement moving forward. And so we like to support that process. So that's something that we've implemented, I think, within the last 2 years. A year and a half.
Less than that, yeah. And what I've noticed, kind of going back to what we were saying earlier about like what my main function is at Child Haven, is just being a friendly, supportive face and to build relationships. It translates to these transition arrangements with kids, as Meambi said, have been on campus a long time, just being a familiar, friendly face in this new, scary environment. And I think that's the biggest positive that this new activity that we've been doing as of the past year or two has really served, is just that familiarity, safety, and comfort.
And I bet it's probably comforting to the foster parent too, or the relative caregiver, whoever they're going to live with, to know that they have your support. If something happens, they can call you guys or get advice.
Absolutely. And we don't want the child to, be at risk of disrupting the placement, acting out, because essentially what that really means is I don't feel safe. We know congregate care impacts development in a negative way. They should be in families, but sometimes that's their happy place. That's it's predictable, right? It's predictable for them.
Routine,
it's
structure.
The routine, it's the structure that's there. So not all of those transitions feel as warm as for the kid, right? We're all saying, you're going to go to this safe, normal place. And they're like, no, I don't want to. I want to stay with you, Mr. Chris. Or I want to stay here with the cottage staff that are really taking care of them. And so we have to really be intentional in how we support their transition to help them feel safe.
Well, that definitely speaks to the kinds of relationships that you're building with these children. And I think that the more that we can make things predictable for our kids, prep them, talk about what it will be like, then it helps them kind of ease into it and get an understanding, or help to paint a picture of what, your next chapter will be. So, okay, let's talk about supporting caregivers. Our caregivers are amazing. They will take children into their homes for one day, for a week, for a year, for 2 years, whatever it might be, until that family has the opportunity to safely reunify. And during this time, those caregivers have a lot going on, right? They're taking the kids to the doctors. They're taking the kids to school. They're taking the kids to visitation.
And listening to you speak about all of the things that our caregivers have on their plate, right?
They're busy.
They're so busy.
And they have soccer practice, and they have to make dinner, and they've got birthday parties, and like all sorts of stuff.
They have their own biological children, and
Yes.
they work, right?
Yes.
Majority of our foster parents work. They're not necessarily stay-at-home caregivers.
Yes.
So they are amazing. So we really need to show up in a way that we're supporting them and we're validating their experiences. So it's, yes, all these things are on your plate and you are serving our kids, and we thank you. And this therapy is needed, and this is how it benefits the child, and this is how it benefits your home environment. It equips you to parent a lot easier, where these therapists and all of these supports are joining in for you. So it's important to frame it as a support that really helps the day-to-day functioning and the challenges that they would face fostering.
And as we discussed earlier, it's a necessary medical service.
Absolutely.
Literally, quite literally. It's a medical service that will help this child develop in a more healthy way. I don't think any foster parent would say, I don't have time to take my foster child to the doctor to get a cast on their broken arm.
Right.
And so it talks about normalizing that mental health related concern as co-equal with any other medical related issue. And like Meambi said, the folks that do foster care are godsends. And
Absolutely.
they're doing work that I can't even imagine doing, with some of the more difficult situations that anybody could imagine. And they have a lot on their plate, and they're so valued. Fortunately, one good thing that came out of the pandemic is just the much more broader array of possibilities when it comes to service delivery for mental health. So, gosh, when I was in graduate school, not even 10 years ago, we never even thought about telehealth services. Now it's everywhere. So, I mean, there's flexibility there. Some agencies provide in-home therapy services. I've been on conference calls with other therapy agencies trying to work out a schedule with the therapist having back-to-back sessions with the kids in that home, so that the foster parent only has to go out there once a week.
Right.
So we try to be as flexible as possible, knowing that all these other things for these children is definitely necessary when it comes to social supports, going to church, going to soccer practice, as you said, but also getting their medical needs met, whether that's a physical medical need or if it's mental health related issues. It's sort of all the same. So we try to be flexible as a department and help facilitate those compromises and arrangements for the families that we serve.
I like that metaphor of, you wouldn't hesitate to take them for a broken arm, right? So like normalizing that, hey, if this child is showing like high anxiety or PTSD symptoms, there's help for that. And then I think the other important thing to really remember is that, yes, there are these adverse childhood experiences, these ACEs, but we can combat those ACEs with early intervention.
Absolutely.
And so while you might look at a 2-year-old or a 3-year-old just thinking it's a normal temper tantrum, maybe that child needs occupational therapy, right? And maybe it's not necessarily like talk therapy where you have this idea of like laying on a couch and, Kleenex in your hand and talking about all of it, but it might be like a physical therapy because the child is not getting their needs met. Maybe they don't realize that they can use all their fingers in the way that, a normally developing child is using, their fine motor skills. So maybe it takes that observation and that evaluation to say, hey, we can do occupational therapy, speech therapy, right? Because if kids aren't getting their needs met, they're going to figure out a way, whether it's, healthy or not, to get that need met. So I like when you said, it's beneficial to what's going on in the household too, right? Like, and I think that that's something that any parent can think about. If you're struggling with your child, or you see that your child is struggling and you don't know what to do, how to respond, even, just talking to your pediatrician about it, they can make a referral to a mental health program. You can start going to support groups and talk with other parents. And they might say, oh, you know what? We got through that with a great OT therapist, and I think that there's so many options out there to strengthen our children's development physically, mentally, that especially our kids that have been through trauma, where we know have greater disadvantages than a child that was raised in a healthy home. So I'm glad that you brought that up, that once you do start having a child receive services through therapy, it can be a game changer for the whole household.
Absolutely. And I'm also a strong advocate. A lot of foster parents that I've worked with, or just caregivers in general, in regards to really helping a child heal from trauma. It's really important that, they have normalized experiences. So I think one disadvantage that happens oftentimes with our foster kids is they don't get an opportunity, because they need so many other structured services. Do we think about their talents, right? And playing basketball, soccer, dance, theater, things like that. So I'm very intentional as well, and kind of putting that out there. Like, I know you're busy, but can we find a way for Johnny or Susie to participate in extracurricular activities? It's important to note that our kids, oftentimes, they don't have the language for what happened to them to really process that. So they heal through play. So they heal through play in therapy, and they heal through play and those experiences and expressing their talents with community, events and activities per se. So I always like to bring that to the forefront as well, to make sure we're paying attention to those parts.
Yeah, I like that, because when you're exposing the kids to other activities, there's all sorts of research studies out there showing that exercise and movement can be just as effective for adults, kids, people of any age, as an antidepressant pill, right?
Yes.
I mean, so let's get our kids moving. Like, there's not... Most schools don't have recess or time to play, let's get our kids out, doing sports or gymnastics, or even just going to the park as a family and playing tag or pickleball, or, something that you're physically moving together. That can be uplifting. It can help get that serotonin running through your blood again, right?
And music. Oh, my goodness.
Oh, music is incredibly healing.
Music heals. And just the arts, and being a part of those expressive experiences, and just art, just painting and things like that. And those are things I think our caregivers can also do at home that can really facilitate a healing space for our kids.
Art can be so incredibly expressive for children, especially if you're processing big emotions that you might not ever be able to say the words of what happened to you, but you may be able to draw something or paint something or sculpt something. It's like art. I'm not an artist. I can draw a stick figure. But I've heard that it can be like a physical process of releasing something.
Yes.
Yeah, I love that. What about our teenagers? How can we support our teenagers that are experiencing some mental health concerns? What can caregivers do? What can parents do? What do you guys do on campus?
I think one of our really most effective tools on campus are empowering conversations. Our teens that have lingered in care for quite some time, or they've had experiences, unfortunately, where they've needed to come back in care, it's important to ask those questions of, how do you feel? What do you think you need? what helps you to feel comfortable and safe in a placement? What does that caregiver look like? You know, a lot of times we hear from them, I've been doing this by myself on my own. I haven't ever been able to rely on an adult. I don't need one now. So it's about empowerment and bringing about their voice and choice in the matter can really, really help support them.
Yeah, I agree 100%. You know, there's all types of different intervention, so to speak, when it comes to different ages and stages of development, especially when kids come onto campus or go into foster care. But I think it really just goes back to, at any age, just establishing that safe relationship. And whether that takes 5 minutes or 5 months, a foster parent or a caregiver really needs to make that their main priority, is to helping that child feel safe in their presence. And with safety comes openness. With safety comes disclosure. With safety comes processing. So being that non-judgmental voice, especially with teenagers, they have learned how to survive out there in the world, many of them. Like Meambi said, they have been doing a lot of this stuff on their own to the best of their ability, and it's very hard for them to go into a home where someone else is telling them what to do. And so it can be a tough balance for a foster parent to strike between giving that autonomy and giving that non-judgmental voice, while also establishing what the rules of the road are within their home, and doing that with love and care and with the mission of safety. I think gives the foster parent a fighting chance of being able to form that relationship and having some sort of harmony within their home.
And go ahead.
No, I was just going to add, and also just kind of ensuring that we're trauma informed. And what I mean by that is really like, what are the realistic expectations? Yeah. So when we think about the impact of trauma and how it impacts development, most of our teenagers chronologically may be one age 16 or so, but socially and emotionally, or even in, cognitively, they're 8 or so. It has a way that, of really impacting that. And a lot of our kids also are struggling with some type of, co-occurring intellectual or developmental disability as well. So it's important that we equipped ourselves with the knowledge of that, whether it's fetal alcohol syndrome or an intellectual disability, a learning disability as well, and being really intentional to just be mindful of our approach with that. We have to consider those parts as well.
And I've seen a lot of concerns from caregivers or foster parents saying, this kid doesn't listen, or they intentionally don't follow the rules. And that may or may not be true, but a lot of the times, related to what Meambi is saying, they're stressed and overwhelmed and might not be processing or remembering what it is that you're trying to tell them to do. They're just overwhelmed. I think Dr. Bruce Perry, a very famous person in the researcher in the field of neuroscience and trauma, said very simply, stressed brains don't learn. And that chronic stress that these children might have been experiencing from very early on, that may have persisted on and off throughout their entire life. And here they are, 16 years old, and they've got a drill sergeant screaming in their face about, do the dishes, do that and the other. And well-meaning as it may be, it's probably not going to produce the results that we want to see. So back to that safety, that gentleness, that understanding of where this child is coming from, I think gives those foster parents a good chance.
So starting small, recognizing the situation, right? I know like there's the TBRI, like I flipped my lid. So if this is your brain, this is your frontal cortex. When, things are going awry, you've got to get that child back to that like controlled like brain neural response. I am going to respond to this child's needs, and I really need to observe and watch and pick up on what the child is trying to communicate before I can expect them to do anything when it's in the moment. But if you know that you've done everything to be the best person for that child, that's all you can do.
In clinical services, especially with kiddos in the foster care system dealing with trauma, I say I'm in the business of planting seeds, not growing trees. And that's sort of such as life for us as clinicians, as foster parents. We might not see the fruits of our labor ever. And then we might, be like me. I've gotten a letter from a kiddo who's now probably in his 30s from the beginning of my career, somehow found my employer and sent me a letter saying, hey, it's so-and-so. Thanks so much for what you did for me when I was 17. And those are great. And a lot of times we might not get that, especially not in the moment, especially with teenagers. And we have to understand that it's not about us. It's about what they've gone through and just planting those seeds to try to help them grow that tree maybe off into the future.
Absolutely. And because it's not about us, I think, to your point, Holly, it's really important that we focus on our own wellness as well.
Yes. When I interview caregivers, I say, how do you deal with stress? And one of the moms said, well, I throw everybody in the car and we go to Costco for the free samples.
All right.
I love that idea.
Yeah.
Or I've had other caregivers say, well, I will take time. I'll go for a massage. My husband and I will do the respite nights, but I mean, and it doesn't have to be big, like, a whole spa day and a mani-pedi facial massage, right? Because who can afford that and who has time to do that when you're caring for kids? But it can be a few moments in your day, right? So what do you recommend for our caregivers?
Oh, I recommend the little things, taking a deep breath. I'm really huge on mindfulness and whatever I can just get access to throughout the day just to try to just lift the steam pot a little bit and stay regulated. I think that's really key. As you mentioned, who has time and the resources, right, for a spa day once a month? That's really not practical if you're fostering a sibling group of 5 and you have your own 3 biological kids.
Well, and
which is more common than we imagine for our caregivers who are amazing.
And you can get out of that spa day and something happens and then boom, you're right back to like a stress level, right?
Yeah. So really just being mindful in the moment and just relishing in that shower that you get for 15 minutes, that helps, I think, a lot more than some people recognize or give credence to. So it's things like that.
And some resources. What are some common resources that you guys recommend for families for mental health?
Mental health related programs through the Division of Child and Family Services. They have a mobile crisis response team that will come out to you anywhere, anytime, 24/7, 365 in an emergency kind of supportive basis. There's a number of parent training types of courses. Meambi, maybe you can speak a little bit more on what the county offers.
So we have the Parenting Project. That's something that's really available in the community. And I think specifically for our families who are serving our kids in care, we're really mindful to have a resource guide and we have a vetted list of providers, right? We really work to expand that where we're really very intentional of reaching out to our community mental health providers and articulating the need, right? And having that list available to our caregivers, to our caseworkers, so we're expediting those services for our youth and our caregivers. As regards to crisis, I would echo what Chris mentioned. We have a mobile crisis response team, the 988 suicide hotline, if there's really an imminent crisis, or just reaching out to our local, emergency services if there's something that you're really struggling with. But again, I think it's important that we're proactive in our approach in addressing mental health as well. So we really want to be sure that our caregivers have these resources available on the front end. I'm glad we're mentioning them and talking about them today. But through parenting, really, how do we enhance those skills, right? Through our pre-service training, our pre-fostering training, we have the advanced foster care program where we're really talking about just adding some more tools to the toolbox, right? To really address those high mental health needs, the complex trauma that oftentimes comes along with caring for our kids. So those are some things we have in place currently.
Tell me one of your success stories. I know I didn't prep you with this question.
It's hard to pick just one, but the first thought that came to mind is there was a little guy that came in and he had witnessed some pretty significant trauma and violence, and he was pretty nonverbal and he wouldn't sleep, and he really struggled. And I had the privilege of responding to him and trying to support him. And I recognized what he was experiencing was really trauma reactivity, and I really didn't want him to go to the hospital and really re-traumatized him. And I would say I tried everything that I that the book said I should do in terms of clinical intervention and engaging him that wasn't working. And then I thought of a song, and let's listen to this song. And I pulled my phone out and I pulled the song up on YouTube, and I looked over and he was sleeping. And he got some sleep. And then the next day, I think I was just walking around campus doing other things, and he ran up to me and he remembered my name and he remembered that song. And he said, "Can we listen to it again? It helped me sleep." And he hadn't gone for days, not sleeping. And so he was experiencing some psychosis, which is normal if any of us would experience psychosis if we haven't slept for 4 or 5 days at a time. But that jumps out at me right now, and it was just so powerful, that he recalled that and he recognized what that connection was for him, and he wanted to do it again. And so, absolutely, and whatever it took to make that time, that particular day, to sit with him again and listen to that song, we did that.
And relationship and safety forming doesn't have to be this grand gesture. Just like self-care doesn't have to be a grand gesture of a spa day, so too does relationship and safety forming with these children can be micro moments repeated maybe throughout the day. Show a song, say hello, make a joke, pat on the back. That provides safety for these kiddos. And Meambi Stories is a great example of the
It's about
many.
connection. And I think my lesson for that day, even as I think about it out loud, is keep it simple. And connecting human to human, is more powerful than we really recognize sometimes.
Yeah, the relationship is often the damage done when it comes to the children that come into care, but the relationship is the cure as well. So we try to focus on that.
Build those relationships, keep it simple, listen to our kids, respond, and throw our own expectations out the door.
Treat them like someone that's worth listening to.
Yeah. And when you listen to them, they will teach you what they need.
Yeah, they will.
Yes. Yes. I love it. Well, thank you, Meambi and Chris, for being here today on our Foster Leader podcast. I really appreciate all of the insight that you shared with us. I think it's so important to have these tough conversations about what it really does look like. As you may have watched Foster Leader podcasts before, there is a huge need for more foster families in Clark County to serve our kiddos, to keep them safe, to help them heal. If you've ever thought about becoming a foster parent, now is the time. You can get started at clarkcountyfostercare.com. You'll receive training. You will receive as much support as we can offer you to just help keep kids safe, give them a loving home, and be a supportive provider. Again, that's clarkcountyfostercare.com, and we'll see you next time on the Foster Leader Podcast.